Now, question 33, and Prof. Matti Aapro will conclude now.
We have 2 questions to finish, which, thank you very much for the comment that we needed this. I did actually add it. So lisinopril or another agent, and we are not going to start a debate about how to go because cardiologists cannot decide among themselves, should be given to these patients with cardiac toxicity. So these are the ones who have cardiac toxicity. Yes, no, or abstain. That's right. Okay, the majority of you say yes. There are, and lisinopril is the most documented one for the time being. Question number 34. Lisinopril or another agent should be given to prevent cardiac toxicity. So what do you do in your practice? You do that, you don't do that, yes, no, or you don't know, or you abstain. Should be given to prevent cardiac toxicity. Then we can discuss.
But if the question is could be, you'll have more.
Okay, so let's revote with the could be, and then we will have a comment from Hamdi. So can we revote? And the question is now, lisinopril or another agent could be given to prevent cardiac toxicity. Yes, no, abstain.
I think that's more appropriate.
I want to know if there should. Okay, it is indeed an option. And now, Hamdi would like to make a comment.
The could be or is really directed to the high-risk patients who really have the risk above the average risk for cardiac toxicity. Who are these patients? From the analysis of the adjuvant studies, we knew that age in certain studies is more than 50, in other studies it's more than 60, but certainly more than 60 is an absolute risk factor, and uncontrolled hypertension or hypertension in some studies, and obesity, body mass index more than 30. So in such cases, in my opinion, the idea of giving preemptive therapy to minimize the risk of cardiac toxicity is warranted, and that where there should be is required to discuss with the patients.
Dr. Nihad, you had a comment as well?
We've been doing lisinopril with beta blockers. What do you do, Hamdi?
Excuse me?
We've been doing beta blockers with lisinopril in such cases.
Yes, actually we have many regimens in this area, and you have to consult with the cardiologist. But I mean, as medical oncologists can do, they should discuss with the cardiologist the preemptive use of an ACE inhibitors or beta blocker, either alone or in combination, according to the other portfolio of medications the patient is receiving.
There was still a comment?
Yeah, with due respect to Dr. Hamdi, but there is no data to support the use of these medications to prevent cardiomyopathy secondary to Herceptin.
Yes, you're right. But you will never have this kind of data because now the usual practice is to give this treatment. And that has been the recommendation of the American Association of Cardiology. That's why it will be very difficult to do this kind of studies.
Hamdi, maybe I can add to this as a compromise. They are useful in order to prevent further decrease of ejection fraction.
No, the question was in patients that you start in. We all agree that patients that have
not for
a
prophylaxis,
decrease in ejection fraction have now evidence that they can and should be treated. How they should be treated I was recently at the meeting where Thomas Sutter gave a presentation. He had his opinion. I asked him about his opinion. What is the evidence? He said, well, I think. I said, no, don't think. Where are the data? And I agree. The data are what they are. It's a debate. If you ask Uwer, for example, he has his own opinion, and there are lots of opinions. But we have to take a decision for patients, and this is what we asked the panel to do, and the panel has done a wonderful job. So I'm absolutely delighted to see that I was able, in spite of all the recommendations of the panel to change everything, to keep on time in the time we were allotted. It's not the panel's fault, it's not my fault that we started late, but it's wonderful to see that you were all here, all attentive, all listening to the panel. I would like to thank the technicians, because we asked them to do something that they did, and they did it beautifully well. Thank you very much indeed. I'd like to thank my co-chair and ask him to give his last words as a co-chair before we ask the chairman, president, leader, big boss of this meeting to give us the last words.
Okay, thank you. I, extend my thanks to a very distinguished panel. I think a great job, and I'm sure we will learn a lot from these answers. And thank you all very much for staying to this time. And without further ado, Dr. Hisham will conclude. Thank you.
It's not a conclusion, but it is words of thanks for all these international figures that staying with us for 2 days, working very hardly to try to transfer a message for education, and also, I hope, inshallah, for research. Thank you very much, and we are now going for the gala dinner, and thank you, and meet you in the 8th one next year. Thank you very much.